All right, so we're going to be talking about ultrasound and the workup for abdominal pain. And I think ultrasound's really good for patients coming to the emergency department with undifferentiated abdominal pain. We can go through several areas in which ultrasound can quickly rule in or rule out some common pathology that we see in the emergency department. This is a nice umbilical hernia. It just kind of looks like a happy face when we see this. We do this thing called ultrasound Doppler gangers where it looks like something else on ultrasound. This was like a Doppler ganger for a happy face. Anyway, so yeah, we can look at small bowel obstructions, appendicitis, gallstones, renal colic, and bladder volumes. And normal intestine usually just has kind of this layered appearance like this. You don't really see much. Air kind of gets in the way. Once in a while, mid-peristalsis, when all the air is out of the lumen of the bowel, you'll see the lumen there with the bowel kind of all collapsed down on itself, and the outer wall being very hypoechoic and should be less than 2.5 centimeters in diameter. And just to remind you, small intestine has the plicae circularis, goes all the way around there, and you'll see on ultrasound what we call the keyboard sign, which are the little plicae here, those little units there. You see them pretty easily on ultrasound. Imagine this lumen is all filled with fluid that's got nowhere to go, and now the ultrasound conducts the sound. The fluid conducts the sound very well, and you start to see some of this anatomy. And whereas a large intestine, you get these haustra, and you could see every segment here. You can make them out pretty easily here on ultrasound when there is a colonic obstruction as well. So that's the difference. The colonic obstruction is a lot larger. I think they're called valvular cononives or something. I forgot the word now. But they're a lot different than the plicae circularis. They're like a lot larger. So that's the difference. Yeah, you can see here kind of like that's colon, and then this is small bowel. You make out those plicae. So how do you do it? You're going to use, I prefer using the curvilinear probe if you have one of these large footprint transducers. It's just going to make prettier images, and it's perfect for small bowel obstructions. And you can see here this peristalsing bowel here kind of going, back and forth. You can see that we got something going on here in the bowel. So the question is, what imaging modality shows the highest positive likelihood for the likelihood ratio for the diagnosis of small bowel obstruction? Is it CT scan? I know you're thinking it's got to be CT scan. CT is better for everything, right? Is it MRI, plain ultrasound, plain X-ray, or ultrasound? And it turns out the answer is D, ultrasound. And this is one of the LLSA questions, and it's one of the times where ultrasound actually outperforms even MRI. Can you believe it or not? But it just shows. It's just so obvious on ultrasound. It's one of the easiest diagnoses you can ever make. And they based that question on this article where they looked at the history and the physical, the X-ray, CT, MRI, and they showed that ultrasound actually had the best likelihood ratio, 14.1, which beat out the other imaging modalities. So that was pretty good. Whether it's in the hands of the radiologist or in the hands of the point-of-care ultrasound, even in the hands of the point-of-care ultrasound person, 9.55, very high likelihood ratio. So you can see how it's pretty straightforward. There's the keyboard sign of the plicae coming across here. This looks like a very typical small bowel obstruction here. Another example, as you're fanning through, you can see fluid. The white stuff that you see in there, that's just some little air. And so you'll see this kind of to and fro, or you could say poo and fro if you'd like to. It's less professional, yet funny. And you can see over here, we're seeing another example here of this sort of poo and fro back and forth from this small bowel obstruction. Another example, and we just have tons and tons of these. And so, and this is just common part of our practice, right? Somebody comes with abdominal pain, they're vomiting, and you might be wondering CT, X-ray, but if you just plop the probe on there out in triage or right there at the in the back when they get into a bed, pretty easy to make this diagnosis. And then you can see the back and forth there again. It's just obstructed. It's exactly how you'd picture it. And again, normally without there being all that fluid in the lumen of the bowel, you wouldn't even see the bowel. You just see some kind of layered shadows coming out of the abdomen, which is kind of probably what you're used to seeing on patients without a bowel obstruction. And this patient actually has some ascites over here. See this kind of this ascites around here? But then in here we can see this bowel obstruction going on here. So sometimes you'll see a combination of pathology another example here, just a bowel obstruction seen over on this side of the screen, right here. Almost, they kind of, for some reason, to me, look like little paramecium. I don't know. I don't know why. Maybe it's these little plicae circularis. Another example here, just that kind of back and forth from the obstruction. And another example here, and just very typical classic looking bowel obstruction. You can actually see here, this is the spine shadow. Here's your aorta, here's your IVC, and this loop of dilated bowel here. Again, 2.5 centimeters you would measure from, like probably like here down to here. Or you could go from here down here, because clearly this loop is like coming around on itself. All right, well, I think you get the picture. These bowel obstructions, I've got a zillion examples of them, but I won't belabor the point. There's oh, here's one with a linear probe here. You can see linear probe and sort of this same appearance. I don't know. I think the curvilinear probe's a little better because you can really kind of stretch out this image. You get a little bit better penetration of the sound. Linear probe, higher frequency, doesn't penetrate as much. It does make pretty pictures, more detailed resolution of the actual wall itself, but I don't know. I like having a little bit better of a bird's eye view with the curvilinear probe. And yeah, you could actually have a closed loop obstruction where it is obstructed on both sides, and so we can see here this patient. It's just kind of going back and forth, and that's what happens with the closed loop obstruction. It's obstruction on both sides, and so what you get is this one little section. The rest of the intestine, when you're doing your ultrasound, the rest of the belly looks pretty good, just some layered appearance, don't really see anything. And then suddenly in one little area, you come across this one section that's this closed loop, meaning it's obstructed on both ends of the bowel. And that's, you can kind of see how it's like coming around here. It's obstructed back here, and then it's obstructed right here. But really what you need to know is that we were scanning this whole abdomen, and this is the only section that we saw any bowel obstruction. So it makes sense then to like really look at the whole abdomen. Don't just plop the probe down and say, I don't see any obstruction. Really kind of look at the whole thing. Just another example here, just a really obvious bowel obstruction. Okay, moving on from that into something that's a little bit more difficult, and that's appendicitis. You're kind of looking around for it. You're looking around, you're compressing, non-compressible tubular structure, you're compressing, and all of a sudden you notice that there it is, and then it's gone again. And so that's the funny thing about appendicitis. It definitely requires a little bit of time. I spend probably, it's like the most amount of time I might ever spend doing an ultrasound. And I spend maybe, 5-6 minutes sometimes just doing these graded compressions. And I know that's a long time to be doing an ultrasound, especially when you're working a busy shift. And, depending on all of your other responsibilities in that moment and the situation and the line for CT scan, maybe this makes sense in your situation to do it yourself. And so, you're looking for a non-compressible tubular structure that's about 6 millimeters and or larger, obviously. And sometimes you'll see an appendicolith in there, and that's blocking the lumen of the appendix. That's the whole cause of the appendicitis. And eventually, when that appendicolith blocks that appendix, it starts getting swollen. The venous drainage can't drain because of the increased pressure from the luminal pressure going up from the blockage. Then you just, it can get gangrenous and perforate. And so the other thing sometimes you'll see is some periappendiceal fat. And then, so you'll look around that non-compressible tubular structure for some hyperechoic periappendiceal fat. And the other thing is when you really get a rip-roaring appendicitis, you'll lose the three-ring wall appearance of normal bowel. So normally you have that hyperechoic inner wall, hypoechoic middle wall, and I should say, sorry, normally you have a hypoechoic outer wall, and then there's a hyperechoic layer, and then there's another hypoechoic layer. And so what you're seeing is that loss of that three-ring appearance, and you're just seeing one ring, basically. And so that's another sign that this is a very dilated appendix. So I'll show you what I'm talking about. So this is the normal appendix. Feast your eyes upon it. Don't see them too often. Although I'll tell you, my medical students can find them on each other all the time. They spend a lot of time trying to look for it. Like first-year medical students will have this scanning session for half an hour. They try to find appendicitis, try to find an appendix. And, the more you kind of dig around that right lower quadrant, here's the iliac vessel here just next to it. We're seeing psoas muscle down here and maybe rectus or abdominal muscle up here. You're basically compressing these, this could be like oblique abdominal here, rectus abdominal muscle. You're compressing these muscle bellies onto this psoas muscle here. That's the whole idea of the appendicitis, with trying to find the appendix. And it will get squished between these two layers. This one's only 4.3 millimeters, so obviously it's not 6 millimeters, it's normal. But yeah, you can kind of make out it's got 3 layers to its wall here, you know, maybe 1, 2, 3. Maybe over here, 1, 2, 3. Yeah, so hyperechoic outer wall, hypoechoic, and then another hyperechoic inner wall here. That's kind of how it appears. Normal appendix, and so then when you start looking for the appendix, the technique you're going to use is this graded compression technique, where you're smushing the psoas muscle here. Here's your abdominal oblique muscle here, and you're just basically smushing those two muscles together. Here's your iliac vessels seen here. And again, the technique, we can see this is probably psoas muscle in a longitudinal plane. We can see the appendix is getting squished in here as a normal looking appendix. And then this is the abdominal oblique muscle up here. But you get the concept. It's this graded compression technique where you're smushing these two muscle bellies together. And here's some vasculature here. Here's your psoas, and here's that appendix coming along here. You see it in its longitudinal plane stretching out across the screen. Again, linear probe. With the linear probe, we see really nice images here in this right lower quadrant on most of our patients. If they get a little bit larger, sometimes I'll switch it up to the curvilinear probe. And this is actually this nice, kind of pretty looking, almost looks like a flower to me with all these little petals coming out. This is what the terminal ileum looks like. And so when I see that terminal ileum, I know that the appendix is probably not far away. Right, so that's what the terminal ileum, or TI, is. You see that there, and you go, where's that appendix? It's got to be pretty close to there. And so that's just a little tip for you. But this is, here's the appendix over here, and it looks like it's not compressible. You can see as they squish it, it doesn't compress. They're measuring it's about a centimeter, 9.8 millimeters or so. So this is that psoas muscle down here, abdominal oblique up here, and they're just squishing those two muscle bellies together and seeing this non-compressible tubular structure that measures more than 6 millimeters. That one still has all its rings there, so that could be a really early version of appendicitis. This is an appendicolith here with the shadow coming down. This is the lumen of the appendix would be over here, and then like the tip of the appendix is like over here, and so you can see how that stone here can block the appendix. And you could put color flow Doppler on the appendix and on appendicitis, and it'll feel very engorged with blood initially, and that's what we call the ring of fire, because you'll see this hyperemia of the appendix. And a couple of examples. Here's another ring of fire here. Here's the vascular stalk that's going to the appendix, ring of fire. This is interesting because you can see the terminal ileum adjacent to the appendix here. So that's your landmark there. That terminal ileum has a very characteristic kind of, I think it looks like a flower for some reason. And here's your 8.5 millimeter appendix over here. Still has its walls. Definitely has some periappendiceal fat on this edge of it over here. In fact, down here you can see some periappendiceal fat, this hyperechoic stuff. Here's another example. They're saying with compression you can see, maybe that's psoas there. I'm not sure. That's definitely TI. I mean, look how beautiful those little petals are that come out like that. So you see that, it kind of looks like a sand dollar, actually, now that I think about it. Yeah, and all things Maui themed, this does look like a sand dollar to me. And over here is your appendix, and maybe we're starting to lose some of those walls a little bit there, but 6.7, so that one just barely makes positive. This one's got, in a longitudinal plane here, we're seeing some hyperemia. We're seeing the appendicolith with its shadow there. So appendicoliths, you can see them here. There's a nice normal-looking appendix. I haven't measured it, but it looks, like it's going to fall within measurements. But you can see here, here's the appendicoliths here, and this is another one here, appendicolith in a transverse view. And periappendiceal fat looks just like this. It looks like this, hyperechoic schmutz. Here, this appendix here, it doesn't seem to have its walls. And so this might be that example I was trying to explain earlier about how it loses its walls. It's just kind of just a fat-looking thumb sitting here with its periappendiceal fat. And let's see what we got here. This is looking like, here's this non-compressible tubular structure right here. And you could see, there you go, pretty obvious. Here's your abdominal oblique up here. And I'm hoping to see some psoas around here. I'm not seeing it. They had to push a little harder. But this looks like some periappendiceal fat right here, this hypercochschmutz. And with the color flow Doppler surrounding it, that what we call ring of fire there. There's some artifact on the screen, but you can see the ring of fire there. A little bit of flash artifact in the color flow box, but you can kind of get the picture and see how that hyperemia comes around that appendix. Okay, so we're going to switch gears. We talked about small bowel obstructions, talked about appendicitis. We're going to talk about gallstones now. This is, gosh, in my patient population, this is like a three times a day I'll make this diagnosis. And I like this little cartoon that I found when I was searching for gallbladder cartoons, because that's what people do. We search for gallbladder cartoons, right? What is it, gallbladder? Can't you see I have a lot to do? And then the gallbladder says, I make these. And then the liver says, you made stones? You're just supposed to hold on to what I give you. Get out, go on. And then kicks the gallbladder out. And then the gallbladder sits to itself, says, I make these. And then this montage continues. And so now the gallbladder is thinking about that sort of interaction, that negative interaction it had with the liver telling it to get out. So then it packs its bags and it notices this sign, art school, apply now. And these look like all, oh yeah, these are all thought bubbles from the gallbladder here. And then they're starting to, he's at the art school now, and then the teacher's saying, you have real potential. And then puts together this exhibition, a stone's throw exhibition. People are saying, oh, genius, incredible. Lifetime Achievement Award, gallbladder. I don't know why this made me laugh so hard from the awkward Yeti, but somehow this applies. So gallbladder sonography, very easy to do in theory, sometimes very difficult to do in practice. So, and I'll explain why. Basically, here's how you work it. You put the probe in the sagittal plane with the indicator towards the patient's head. Now, the patient takes a deep breath, and as they do so, you sweep along that subcostal margin. And by when they take that deep breath, that gets the gallbladder out from under the chest wall. And so when it gets that gallbladder out from under the chest wall, suddenly the ribs go away, and the gallbladder comes right to the probe. And so that's really important. Take a deep breath, okay? And then you should be able to see it as you sweep underneath that subcostal margin. Now, you can roll the patient on their side, and as you roll the patient on the side, these loops of bowel right here kind of fall out of the way. So you're having difficulty with the subcostal sweep. Second thing I do is I tell the patient to roll on their side like they're sleeping on their side, all the way over, all the way over. Good. And now I tell them to take a deep breath. And as they take a deep breath, I start fanning through and trying to find the gallbladder. And so more often than not, you'll get lucky here. And as those loops of bowel kind of fall out of the way, as you're fanning through, suddenly you should start to see the gallbladder. And when they're contracted down, they're little tiny little cute things. And so another technique, so we got the subcostal sweep, and then we got the roll them on their side. And if that still doesn't work, then you switch probes and you use the cardiac phased array probe. And you're going to do what's called X-7. X stands for the
X-7 approach,
for the gallbladder. For the xiphoid process. And then 7 millimeters, 7 centimeters,
laterally,
to the right laterally.
place the probe perpendicular
Put it right on the skin.
to the patient's skin, and more often than not, you're going to find the gallbladder in this general area.
So that's the idea. And this X-7 works better in patients who are a little bit larger. And so, okay, so moving on. This is what makes gallstones so beautiful. You got this gallbladder, you got these gallstones here, you got the all coming together with the shadow, and it's just it's such good times whenever you see these classic gallstones. The other thing about gallstones is cool. Not only are they echogenic in the shadow, but they actually are gravitation dependent, and they will move when you move the patient around. Now, you can't see what I did here, but I sat the patient up, and that caused the gallstone to walk up. And then I just like to reverse the video to make it seem like the gallstone is now crawling back down towards the neck of the gallbladder. And so, yeah, that's what makes ultrasound so sensitive and specific for gallstones. Here's another example here of the gallstone down in the neck of the gallbladder. The tricky thing here is that this is all liver, and then this right here is a gallbladder filled with sludge. And sludge and liver look basically the same on ultrasound, so it's easy to mix this kind of stuff up. Here's an example of when you've got the same exact patient, the same exact gallstone, same probe, curved probe, but what did you do differently in order to get this to shadow? What machine adjustment did you make going from, this thing isn't shadowing, maybe if I turned up the good frequency. So when you go to the resolution mode or turn up the frequency, you get that shadow to appear. And then there's another pitfall with gallstones called the West sign, which stands for wall echo shadow, which means the gallbladder is contracted down on a stone. You can see the anterior wall, you see the echogenic stone, and then you see the shadow coming down. So wall echo shadow. You can imagine if you had a gallstone and then you went and ate something really delicious that had a lot of fat in it, all that cholecystokinin causes your gallbladder to contract, right? And then it contracts all the way down on the stone. So the only thing we really see when we go to look for your gallbladder is just a shadow coming out of the liver. And that's what the West sign looks like. Again, this is not the gallbladder. This is also not the gallbladder. This looks like a gallbladder, but it's not. This is the duodenum. You can see there's some air here in the duodenum with some shadowing coming down. But again, this is definitely not the gallbladder. People get the duodenum and the gallbladder confused sometimes. In fact, here's a good example. So you can see this structure here. It's got some shadows coming out of it. Almost looks like some comet tails, right? So that could be some air and some fluid mixing together. And somebody's saying, is this a Wes? Is this a Wes? And you guys are smart now. You know that's definitely not a Wes. That is the duodenum. There's air in the duodenum that's causing all these crazy shadows coming out of there. And some are hyperechoic, some are hypoechoic. You got air mixing with water. And the way the sound hits it, you get a comet tail. And this is just straight up air and fluid in the duodenum. All right. This, on the other hand, is a Wes. I know they look similar, but this is a very confluent shadow with all these gallstones here and making just a big shadowy shadow. And so the anterior wall of the gallbladder is seen up here, and there's just a bunch of stones, and the gallbladder sort of contracted down on these stones, and we're seeing all the shadow coming out. That's a classic West sign. So what else? I talked about sludge for a minute, and sludge, when it's not totally filling the gallbladder, you'll see it kind of meniscal layer out on you like that, like a meniscus. And so that's sludge. It does many times look like the liver, although this liver looks a bit more hyperechoic than that sludge does, but that's the idea. The gallbladder wall, we talked about how to measure it. It's going to be along that anterior wall. It should be less than 3 millimeters. And yep, anterior wall, less than 3 millimeters for the gallbladder wall. Now, a contracted gallbladder to me is one of the most adorable things you'll ever see on ultrasound. I mean, just look at this little guy, contracted all the way down. You can see sort of that hyperechoic outer wall, hypoechoic, middle wall, hyperechoic, inner wall. And so you see those 3 layers of the wall there. And then it's also like hyperechoic behind you here because the sound is going through the gallbladder, the bile in here, the sound speeds up and it's hyperechoic behind that gallbladder. And so when you have a contracted gallbladder, they're just, I don't know how to describe it any other way than it's like a magical little moment for me whenever I see one. I get really excited. I mean, look how adorable that little gallbladder is. Now, you know, in this case, they probably could have decreased the depth and stuff, but still, it's just, love it. But the problem is with these contracted gallbladders, they do kind of look like the duodenum. But notice that this duodenum here is like outside the margin of the liver. It's subtle. I'll give you that. But the duodenum, the outer wall appears very hypoechoic to me. There's just a very much more prominent, I would say, hypoechoic ring around that duodenum. Whereas with the gallbladder, it's definitely a very prominent hyperechoic ring around that gallbladder. Gallbladder hyperechoic ring, duodenum hypoechoic ring. And then the gallbladder is inside the liver. It's tricky though. Now, when you get a thickened gallbladder wall, you can measure from here to here. There's a thickened gallbladder wall here. We got our stones. This is what cholecystitis really looks like. This is it. This is like I'm on the phone with a surgeon when I see that. That patient's not going home. These are 1 centimeter hash marks here. You measure this, it's definitely more than 3 millimeters. That's a, thickened gallbladder wall. And this is what pericholecystic fluid can look like over here. We see the duodenal loops back here. Here's your gallbladder and some pericholecystic fluid. Also here, we're seeing pericholecystic fluid kind of wedge out here, anterior to this gallbladder. You would measure this gallbladder along that anterior wall. Looks pretty thickened to me as well. Pericholecystic fluid. Another example here of cholecystitis. We see the thickened gallbladder wall. We see a gallstone down here, and we see some pericholecystic fluid up there. Oh yeah, we did a study comparing ourselves to radiologists, and it was prospective, and we were looking at pathology reports, and then we on a patient went to the OR, and then people didn't go to the OR. We called them all back at 2 weeks, and we had a bunch of different people doing these scans. It wasn't just like me and my fellows. It was like, yeah, some fellows and a bunch of different attendings, a mixed bag of folks doing this ultrasound. And we enrolled 189 patients. And basically, the test characteristics are here. Our sensitivity to pick up cholecystitis, that was the point of the study, to try to find cholecystitis. We were 87% sensitive, and radiology was 83% sensitive. All the patients went for radiology ultrasound. And then on the specificity, I should say the negative predictive value, we were pretty good, 97% negative predictive value. Specificity, though, radiology beat us a little bit. I mean, we're really kind of, basically the same. We're a little better on sensitivity, they're a little bit better on specificity, and overall, it's not a perfect test, but it's a pretty good test, whether it's in the hands of the person at the bedside or a formal ultrasound from radiology. Okay, so moving on to biliary ultrasound, this is to try to find the common bile duct. People always want to know, I want to find the common bile duct. I want to find the common bile duct. People ask me this all the time. It's so cute. So here's the portal vein, and here's the CBD, and this is the hepatic artery. You'll notice that the hepatic artery kind of comes and goes with the portal vein. However, the CBD is very reliably linked right up next to the portal vein. And so really my goal to try to find the common bile duct is to try to find the portal vein. And so if I can see, there's three structures here on the screen. A little bit tricky, but I can see the IVC down here. My portal vein has very hyperechoic walls to it. And so the deepest tube, if you will, is the IVC, then portal vein, and then the most superficial tube, and they all kind of run together, is that CBD, common bile duct. Now, hepatic artery, I can kind of see it coming into view here, but that's the idea. So again, IVC, portal vein, and then just on top of the portal vein, we'll see the CBD right there. Yeah, you can throw some color flow on there, and you'll see. It's not my favorite thing to do because you do get a lot of flash artifact, but and by and large, the CBD shouldn't fill, obviously, because there's no flow going through it. At least not enough flow to pick up a Doppler signal. So that's one way you can try to find it. But the problem is the patient's breathing it out, and you're going to get a lot of artifact on the screen when you use Doppler. Okay, so we're looking at here IVC, portal vein, CBD, duodenum filled with stuff, hepatic vein coming across the screen here. So I'm going to go ahead and play this video and keep an eye on the portal vein, CBD, hepatic arteries right here. And we zoomed in. Here's that CBD stretching out across the screen there. So you would measure, inner wall to inner wall, this distance here, 5.6 millimeters. And again, up to 6 millimeters is normal. IVC, portal vein, CBD. Pretty straightforward. Okay, so what's this down here? Good, IVC. Now, what's this? Good, portal vein. And so therefore, this must be the CBD. And interestingly, this CBD is pretty dilated. These are 1 centimeter hash marks, so it's looking like it's getting there. But this is all the intrahepatic ductal dilatation that you read in the radiology reports. What it looks like here. You can kind of follow all these ducts right into the CBD, like we're doing here. And so this is, believe it or not, this is actually the portal vein right here. It's all kind of just out of plane, barely out of plane, but we look on top of that hyperechoic walled portal vein, and we see the CBD with this stone here in the distal CBD, and that's choledocholithiasis. This is a really cool ultrasound. You could see how all of these ducts are really dilated, draining into this CBD, and this giant stone is here, choledocholithiasis. Okay, so for the summary of the gallbladder, just have the patient take a deep breath, roll the patient left radial decubitus. If you're still not getting images with a curved probe, then switch to the phased array probe. Go X minus 7, go between the ribs. Sometimes you're X minus 10, depending on how big the patient is. Duodenal air can look like gallstones, and just be aware of that. Duodenum should peristalsis on you, though. And the wall echo shadow, if you can't find the gallbladder. You're looking around, but you see a big shadow coming out of the liver, you're like, oh, wait a minute, is this a contracted gallbladder, stone in it? Have that in the back of your head always when you're scanning if you can't find the gallbladder. And then to find the CBD, just look right on top of the portal vein. Okay, we're going to turn to the kidneys now. And a medical student did this drawing, really cool drawing of the kidney and the color and everything. So, back to this cartoon again. Where are you headed, gallbladder? This looks like the kidney talking, right? They both have stones. I have to get removed. Well, that's outrageous. Why? On account of I maked all these stones. And then the kidney's saying, seriously? They were removing you for that? Hey, bladder, looking good. I made these for you. And then it's the same thing, like the kidney's trying to get rid of its own stones. It's looking a little bit concerned now, and then look how happy the bladder is to get those stones. Anyways, moving on now, talking about the actual, what does a kidney look like? It's kind of fun to put the color flow in the kidney. I'm not going to lie. Whenever I'm testing out an ultrasound machine, I go straight to the kidney, and I start putting flow on it just to kind of, I don't know, test out the machine a little bit. You can really see the flow there. The renal ultrasound protocol, though, involves looking at the kidney's upper, mid, and lower pole, fanning through, and appreciating that the kidney sits right on top of that psoas muscle. This is the right kidney, obviously, because this is all the liver up here. Right kidney is always way easier to see than left kidney because of the liver. You can really get anterior approach, use that liver as your window to see the kidney. I mean, this is our Morrison's pouch. I think we're all very comfortable with that. When you do get a blockage of the kidney from some gallstones, you could have some obviously some hydronephrosis here, but whenever you see anechoic stuff in the kidney, you got to really differentiate best you can if it's within the renal pelvis, okay, and kind of blockage is coming up into the calyces, or are these individual spherical structures out in the renal cortex. And so you got to differentiate the cortex from the pelvis. That sounds really simple when I say it that way, but sometimes with some extreme pathology, it may be difficult because you may have actually a mixed picture of cysts out in the cortex causing some obstruction of the ureter, and thus you have a mixed bag picture. So hydronephrosis just looks like a little glove, and this is an example here. Here's your psoas. Where'd it go? You can see psoas muscle down here, and we're just fanning through the kidney, and we can see that renal pelvis, and right in the beginning we see the ureter coming off of it. And this is like mild hydronephrosis here. I'd probably call that mild. Mild is when you can definitely see the pelvis there starting to splay out. You might even see a little bit of hydroureter, but this is early or mild. Your cortex is very intact here. Here's another example of hydronephrosis. This is probably more, I don't know, more like moderate because I'm starting to see a lot of coalescing here of the calyces as you go out into the fingers, or if you will, of the kidney. This would be the palm of the hand, and as you start to lose the fingers, as they all kind of coalesce together, you start getting to a moderate range. Still have a pretty good intact cortex, though. Another example here. This one's severe hydronephrosis. We've kind of lost all of the fingers of the pelvis, and all we have is like a thin margin of cortex seen out here. So just an anechoic region inside the center of the kidney, and then a squished out cortex. That's severe hydronephrosis. We lost the fingers of the glove. Some people call this a bear claw. Another example here, just severe hydronephrosis. No fingers at all, just an anechoic giant area with this thin layer of cortex out there. Somebody called this the gallbladder, and I did see the gallbladder for a second there. It was right out here, just that little rim of gallbladder there. But here's the kidney, and this is a giant renal cyst that's part of this kidney. So when you see a big anechoic thing in anywhere near the kidney, the odds of it being a renal cyst are very, very high. So that's always my kind of like, I have to convince myself it's not a renal cyst because that is so unbelievably common. And if it's really not part of the kidney, then you're looking in the other organs for why you would have such a dilated cystic structure. I mean, what's in differential diagnosis when you have a dilated structure here? Obviously, you put the probe down, depending on what the probe is, you're thinking AAA. This could be the gallbladder. This could be something in the ovary that came all the way up in the upper abdomen. So just sort of keep that in mind. It's always could be a few different things. So now we're looking at the bladder here. When you measure bladder volume, you want to measure it in 3 planes. Here's a transverse plane. And so in the transverse plane, you measure the width and the height. And then you unfreeze the machine. Once you lock those 2 values, then you unfreeze the machine and you measure in the sagittal plane, lock in that 3rd value, and then it'll calculate the volume for you. Or you could just do length times width times height, divide by 2 if you didn't have the calculation software. But that's basically it. We're looking at the curvilinear probe when you're looking for small bowel obstructions. I think that's probably the best probe to use. Linear or curvilinear when you're looking for appendicitis. I usually start with linear unless the patient's pretty big. And then curvilinear or phased array looking for gallstones. Same for kidney and same for bladder. Thank you very much and hope to see you guys all in Hawaii.